Welcome to EOB, where the fine print gets airtime. We take the plan docs and hot takes one clause at a time. If benefits feel murky, confusing, or buried in law, we'll translate the jargon and call out the flaws. No spin, no sales pitch, just what benefits folks should know. Health and welfare, decoded, let's get into the show.
Hey everybody, welcome back to this episode of EOB. I'm Julie Selesnick here with my partner in crime, Justin Leader. Hey, Justin.
Welcome back, everybody. So a little bit of continuity. There was an episode a few episodes back where the big joke was Justin's bringing a special guest. And for those that listened to that one, the shtick was I had a cold sore that was like horrible looking. So when we were talking about guests, I'm like, yeah, I brought one, the cold sore. So that's the underlying joke. Luckily, the cold sore is gone now.
And what was funny is that we promoted that as a clip and people were like, oh, that's nice.
Yeah. Look at, yeah.
Sorry, I didn't mean to make fun of you. And so to make it up to you, I'm going to first of all congratulate you. Justin won yet another leadership award this week because he wins a lot of awards. He's an award-winning leader. Mm-hmm. So tell us about it. What'd you win? And congratulations.
Thank you. So I'm in an organization called Vistage, which is a multinational organization focused on executive leadership. And I've been a part of a peer group for 3.5 years with the lovely Kirsten Urich, who is a fantastic exec and leader herself. And I was nominated for our region for a leadership award. And they give out one per year. And I found out a few days ago all the nominees, and I'm humbled because many of those nominees are so worthy of this award. So it was really quite an honor, and thank you for making me blush, Julie.
I wish we had an applause button. This is so inappropriate, but I mean that. Yay!
Thank you. I take leadership seriously. I'm very blessed. I got the last name from my grandfather who adopted me, and it's a lot to live up to. So for me, I want to take care of my people and try to be a good steward of the community. So,
well, that's wonderful. Thanks, Mom and Dad, for Selesnick. All right, what should we talk about? A lot of stuff is going on.
Yes,
We've got. It seems like we have to talk about PBM because that's all anyone's talking about. We've got the FTC settlement consent order with Express Scripts and all the Cigna affiliates. We've got the DOL proposed rule, which you can submit comments up until April 15th on those. Then we have the CAA 2026. And we have the Stern v. JP Morgan case. And so those are just a bunch of different things all about PBMs all happening at once.
and listen, we would be silly not to state, or at least it kind of bugs me because there are multiple components of the health and welfare industry that should be scrutinized and are being scrutinized. But I feel like PBMs are the focus right now, as they're the lowest hanging fruit, the fall guy. And it's a domino in a series of dominoes that will fall. But yes, let's start with the PBMs. Yeah.
And even I guess I left something out, is just the market's just enough. If you look at it, you've got, the Eli Lilly just saying we're going direct to employers. That's sort of a new development. And if that starts to happen with more drugs, I think that's another sort of crack in the model. Then we've got, Trump Care. People are opening pharmacies all over the place. It's like you can't shake a stick and not hit a new straight to consumer or straight to employer pharmacy. What's going on?
Oh, dude. Well, you're right. It's enough is enough. And people you FAFO, you fool around and find out eventually.
Stand for fooler?
I don't know, it doesn't. We can say the F word, fiduciary. No. So with nerd, I am such a nerd. With that being said, literally, what is it? Spread pricing, the rebate games, broker compensation tied to PBM, the fact that we, as the United States, pay more than any other developed nation for drugs. Bullshit's got to stop. And even something in the FTC settlement, hey, guess what? Your rebate aggregator now has to move from Switzerland to the United States. The tomfoolery is immense.
Which is pretty funny because also you can't have rebates anymore in the settlement. And so they just have to move home and you can't have business anymore doing what you're doing. Like, oh, well, that's not true. There'll still be rebates. They just have to pass through. So you have to move back and give back all the money.
I got to tell you, like, I was even talking with my team because, we do a lot of compliance requests and help plan sponsors try to be prudent fiduciaries. And, it's this, okay, all of these covered service providers assign gag clauses on behalf of plan sponsors, gag clause attestation saying there's no gag clauses in the contract. And then they take it a step further, and usually the health insurer and PBM will say, oh, we'll take care of your RxDC reporting. And what's contained within that reporting? The trail of rebates. Mm-hmm. And then you request that reporting, and they tell you no. And I'm talking with my team, I'm like, we need to educate employers that they should be requesting this information, making sure that they're compliant under CAA 2021, and then not being okay with it, but like understanding that I've only ever seen that data from one PBM. Yeah. Every other one says, no, we do it in aggregate. We're not going to give you to a plan sponsor level. Like, it's absolutely frustrating.
It is. And so I think it's pretty fair to say that most employers still don't know what portion of the rebate gets held back. Some portion of it definitely gets held back. And it's for, aggregator fees, administrative services, things like that. But without getting your granular reporting, how can you know how much?
You don't know.
Yeah, if you don't know, now you still don't know.
Yeah.
It's the opposite of the song.
Shout out Biggie.
So I did misspeak, though, just to let me not make anyone think that I think that the FTC settlement says you can't have spread pricing. But what it does is says that, so the settlement so far is only with ESI and Cigna companies, but the FTC has asked for another month because to try and reach the same settlement with Caremark and Optum, and we'll see what happens. But basically, they're going to have a standard offering, the ESI going forward and affiliates. And the standard offering does a lot of things. It eliminates spread pricing, eliminates rebate guarantees. It prohibits tying manufacturer compensation to list price. It requires that the member's cost share can't exceed the drug's net cost, which is great, right? That you'd think that would already be the rule. It expands reporting to include drug level and claim level data and disclosure of broker and consultant compensation. And it gives retail community pharmacies a sort of defined acquisition cost-based reimbursement pathway, although I was reading some of the comments submitted to the FTC, and I think a lot of independent pharmacies are worried that since they didn't set an actual baseline, that it'll be too low, and they're concerned about what that price will be.
Interesting. Mm-hmm. Man, this is going to do a lot to shareholder value.
You'd think so, right? Except oddly enough, ESI was ready for this, and they did an earnings call the next day. I think their stock went up after they reached this settlement, and they at least reported publicly that they don't see that this is going to impact their earnings at all. And they're going to emphasize patient choice. See, they have to have this offering, but it doesn't mean they can't still offer all the existing things. Now, there are provisions in it that say, hey, you can't sort of use strong arm tactics and discourage people away from this. And in fact, I think they have to spend like a whopping $10 million on promoting this and making people aware of it. But I think that they're I think they do predict that like half of their book of business will move to this within some amount of years. I read that somewhere. So I'm not exactly sure how it's not affecting what they think their future earnings look like, but interesting to find out why.
We know marketing and sales, either you control the narrative or the narrative controls you. Mm-hmm. So they're going to run with this narrative, and they're going to provide people with the option to stay, as you said, in the traditional model versus this new model. My question is, how is the balloon going to be squeezed? And I know that when we had Jamie Greenleaf on, we talked about the perception of fees and how people are like, oh my God, am I going to have to pay a separate fee or a larger fee? Let's go back to the manipulation that we see now with rebates and some administrative services agreements where rebates are retained and the agreement is like a negative per member per month fee, which is just, if you think about it, like that doesn't really make a hell of a lot of sense, or there must be a lot of profit in rebates. What is the narrative going to be, and will buyers be smart enough to tell the difference between paying upfront versus paying a hell of a lot more on the back end?
Well, if they're following other developments that are happening, they're going to have to make sure they're getting fulsome compensation disclosures. And if, there's now litigation going ahead on prohibited transactions, that's the sort of JP Morgan case that we mentioned at the beginning. And so a prohibited transaction under ERISA, so this is only ERISA covered plans that need to worry about this, but everyone has to worry about it. We'll get to that afterwards. But at least for ERISA plans, any time you enter into a contract with and transfer plan assets to a service provider, that is a prohibited transaction. That's where it starts. And there has to be an exemption, something that makes it okay. And so here, what the defense to this would be, well, this was a contract for something that the plan needs, but you have to show three things to win this defense. And the three things are: one, this is a contract for something the plan needs. Okay, PBM services, I think you sail by that one, right? Number two, the terms of the contract are reasonable. I think that could be difficult with lots of contracts, not just PBM contracts, lots of contracts that could be difficult. And you just mentioned keeping all the medical side rebates and having a negative admin fee. That suggests right there that there's a lot of money that is not, that the plan is giving up and losing. And then the third one is that you have to show that the compensation being paid to that service provider is reasonable. And so I think that's going to be an uphill battle. Obviously we talked about this a lot on the show with Jamie, but this is sort of where everything is starting to gel, because we also have, new DOL regs requiring disclosures and CAA 2026, which among other things requires better disclosures. Although CAA 2026 says that, it basically says any model based on rebates and spread pricing that's unreasonable and they have to pass through. So I don't know how this is going to all shake out at the end.
I mean, there's a ton in the CAA 2026, but do you think it's coincidence that the FTC mandate for Express Scripts is occurring at the same time that the DOL is seeking commentary regarding these proposed PBM rules?
I think all of these things are gelling at the same time because they've all sort of, as you know, all of these reforms keep getting introduced in every Congress and then they don't pass. And, it's always a different bill that we're all excited about and then it doesn't happen. And this time it felt like a concerted effort was happening at every branch of government. This is happening because something has to happen to make healthcare more affordable. And I think affordability has become an important concept finally in sort of the general conversation. So it's not just transparency, it's transparency and affordability. And to do those things have to change because obviously healthcare is not affordable and we're spending $5 trillion a year.
Almost six.
Which is ridiculous. And we got to get rid of some of that. Yeah. And so this is a first step in that direction.
If EBSA's listening, Julie, you might remember back when hanging out with Karen and having discussions I want my EBSA badge. I just wanted a badge. So if EBSA's listening, if I could get what do they give to kids when they visit the police station?
Yeah, wings. Oh, I was thinking airplane wings, but he does. He really wants an EBSA badge. And he's a very good EBSA investigator. He'd be a good one.
Dun, dun, dun. Yeah. But no, I think we have some serious talent at EBSA now that's really, looking at this in a way that should be taken seriously. And the tide feels like it's changing in a positive direction. Still a lot of work to be done.
I know, but it does feel like the tide is changing. And, certainly this is the most action we've seen in a long time. And, I just think that it's really going to be I'm surprised that we're not seeing any movement on the medical side and a little disappointed.
Yet.
Yeah. But I guess this is a little bit easier to tackle almost because everyone seems to get this more. I don't know why, but the medical side is super. I mean, the PBM side is complicated, but people can understand what a rebate is. You explain it all the time. It's like Kohl's cash, and and then you're not even getting all your Kohl's bucks back, and that's very irritating.
It's very irritating. I love my Kohl's cash. You overpay for something to get a portion of your money back. It's essentially a rebate, I think it resonates because most of middle America has shopped at Kohl's at some point. Leah Lewis and I were talking about this and clowning around, but it's relatable. And let's face it, our society, most of us are on a prescription med. I think I'm on like 6 because I'm a cardiovascular nightmare. But with that, we feel it. But I think we're feeling it in other areas too. Every time you have to pay towards your deductible, think about that. You're not only paying premium out of your paycheck, but then probably copays, deductibles on top of that. Like, it sucks. Like, the system is very frustrating for most people.
It is. And so one of the things I do like about the FTC settlement is like, hey, guess what? Now you don't have to pay more for the drug than, in your copay. Like, now, sort of, sometimes the drug costs way less than your copay, and they'll still collect your whole copay and keep it. And that stinks.
I feel like it's Wheel of Fortune, or like it's like drug price roulette when you go to the pharmacy now. Okay, am I going to use my Good RX card? Am I going to pay cash, or am I going to use my insurance?
Yeah, and you're like, what you do? You're like, what's behind door number 3? What's the best price? And you like, at least though, with drug pricing, you can do that. And you can say, what's the price of Good RX? Do you have a card? What's your price? What's the price if it's cash pay? What's my price with my insurance? With healthcare, on the medical side, there's you don't even get your Colbucks back.
No,
it's nothing.
No.
It's like, stupid you for thinking that you'd ever be able to, 1, know what you're paying, and 2, get any of it back. It's just not even like a thought yet.
Somebody asked me, how is it working in this industry? And I said, well, it's kind of like a colonoscopy without anesthesia.
Yeah.
Some days.
And then when you ask for things that seem very normal in every other aspect of life, it's treated as if it's the most absurd request ever. Like,
why would you be asking that?
Yeah, we've had that happen before.
It happens once a week.
But one thing, just so you guys know, Justin and I asked a carrier once, and this is a pretty small group. We're like, can we get the RxDC information ourselves? We're going to do the reporting. We want to look at it. And Justin asked first because this is his clients, and they were like putting it off. And then he sent the email and put me on it and asked again. And then they wrote back and they were like, we're going to have a staff meeting tomorrow to discuss it. And it's like, well, A, don't tell us that. That's weird. But like, they had to have some high level staff meeting and then come back and say, and then what did they come back and say? What do you want it for? None of your business. The plan wants it. You're a service provider. That makes me crazy.
Yeah, it's very frustrating. And I joke around like it's the punk rock in me. I hate being told no. But like, this is stupid shit to say no about. Like, especially with a plan's money and their people's money. I mean, we often forget a lot of this is commingled dollars. Like, come on. And, it's frustrating because we have to work with some of these these vendors who happen to be covered service providers.
Yeah.
And they're not evil people. And they want you to play ball, but like at the end of the day, like, dude, that's my client. Like, I have to protect them and help them be a good fiduciary, good steward of assets. And at the same time, you want me to play ball. To play ball means that I have to screw them over.
Yeah. And this is the big problem though, is their clients are not your clients. Even though people think that and say, well, I'm a client, I'm a customer. You're not the customer. Their shareholders are their clients. The providers are their clients. You're the people that make it all work, but they don't really, you're the hostage. And because of the system, the way it's developed, the way it has, imagine if you were in a store and you bought something and said, can I have a receipt? And the answer was, for what? What? Like, what do you mean for what? So I know what I paid and I can look at it and make sure I paid the right price and it matches the price tag. Well, here, you don't even have a price tag, first of all, so that would never happen. And then if you ask for a receipt afterwards, like an itemized bill, I mean, it shouldn't be this hard to figure out what something costs and make sure you paid what it was supposed to cost. And it's just so hard.
Katie Talento put out some article that got shared crazy on pretty much demanding itemized bills if you're a patient, and UB04s and all that stuff. I have a dear friend who said, hey, I saw that. Do you know who Katie Talento is? I'll be like, yeah. Katie's been around for a while and does really awesome work. And I read this article that she wrote, and I have my bills. Can I come by your office? And I'm like, sure. And literally came in, itemized bill, EOB, and UB04s. And it wasn't like an expensive procedure, but it was a dermatology visit, and something was removed during the visit. And like, lo and behold, duplicative billing as well as upcoding, like in this one small under $1,000 bill. And it's like, here's somebody that has educated themselves off the street. They're not in the industry. They heard this thing, and now they're like she texted me yesterday. She's like, I've been on on hold with the billing department of the medical center for an hour. And she goes, I'm going to win this. And I'm like, good for you. And she's like, they're looking into it with the coding department. So like one minuscule example, but like think about the investment of time there to actually go request all this information and fact check. And I feel like, I use this Reaganism a lot, we're in this constant state of, we want to trust, but we have to verify and verify again and make sure the math's mathing. So it's nice to have like the government maybe step in and propose some of these rules. And I hope between this and the litigation that we see that move towards transparency and fair pricing, because we're not in a capitalistic system right now. We're in like
the Gilded Age for healthcare. It is like a Gilded Age system for healthcare, and it's a monopolistic, anti-competitive atmosphere. But without being too negative, it does feel like all of a sudden a lot of things are happening that suggest that change is on the horizon, which is good. And I think there's like, there's like a anti-competitive contracting practices bill that's back in Congress that seems to have a lot of bipartisan support. I think it was introduced by Elizabeth Warren and Josh Hawley. And so this is one thing I like about politics, is people on opposite ends of the political spectrum are both like, feel the same about things in healthcare. Healthcare is really, truly can be a bipartisan place, because most people want to have affordable, good healthcare and, be able to know what they're going to pay and pay that amount and access good care in return. It shouldn't be this hard.
Even look this week, we got probably two polar opposite personalities. We got Mark Cuban and Trump. Cuban's drug program, Cost Plus, and then we got Trump RX. And like, Mark's actually like, oh yeah. But Trump RX, it's it's doing its thing, and I'm doing my thing, and you would think those two, which in any other setting probably don't like each other very much, or saying healthcare's screwed up, we got to fix it, right? Or who is it, Bernie Sanders, and who was the other guy? I think they sponsored a bill, Sanders and somebody else.
Oh yeah, well, Braun Sanders, yeah. And now Braun is the governor of Indiana and passed all these awesome bills. So Indiana is like a really cool place to be if you're in employer-sponsored healthcare. And also, if you're in Texas, if you're a payer, you can ask for an itemized bill from a hospital and you get it within 30 days. That's a Texas law. But Indiana passed all these laws, and it makes TPAs and PBMs fiduciaries to the plan's sponsor. And so you have to act with prudence, loyalty, transparency, and you have to respond to requests quickly. They also passed laws requiring that data, if it's requested, it be provided within like 15 days. They have a right to get 835s, 837s. It's like crazy.
See, Julie, it is possible for the American people to be able to afford healthcare in this country.
We need to get, Bernie Sanders, mittens and all. We need to get him on the podcast. Like, that would be great.
We love Vermont.
Well, yeah, but even so, Vermont. And now Bernie's been about healthcare his whole life and all about Medicare for all and trying to make it better. And Vermont is messed up. Yeah. And it's not his fault. He's obviously not like the governor of Vermont. But I mean, it's so hard to make change, even when you're powerful, even when because it's the entire system. It's not any one player or some like bad person. We've created a really bad system, and we need to fix
Kerfuffle.
It is. Kerfuffle.
Is that Yiddish?
It's Yiddish, and it's like if you get in a little fight, it's a kerfuffle.
Oh, that's a kerfuffle.
Yeah.
Okay. All right. Well, this is kind of a kerfuffle then.
But I do think things are changing. And so one of the things that's going to change with CAA 2026, it doesn't go into effect right away, but it requires 100% pass through of rebates, fees, and other remuneration tied to drug utilization and spend for ERISA plans. And so that is a big deal. It also limits or eliminates spread-based pricing economics because it has sort of different compensation rules. So that's a big change. And I am not sure, how the system will adapt to this and what we can do now to you could do that now. You don't have to use a model that has rebates and spread pricing.
They do exist.
Yeah.
Yeah.
And in fact, because of this FTC settlement, even if ESI is the only one that settles, they now have to have a standard offering that doesn't have those things. And so why wouldn't you say, well, if ESI is going to bid and you want to bid, if you want one of the big PBMs, I want a standard offering. And so don't bid unless you're going to offer something like that too. I want to compare those. I mean, you'd be crazy not to do that.
So enforcement mechanisms. So enforcers, statutory penalties, and compliance requirements. So statutory penalties, have these been defined? What the penalties are for non-compliance? FTC, that's pretty serious as far as that goes, but in the CAA 2026.
So, the non-compliance is the same as it's sort of in there, which is a 15. It depends on what we're talking about. Okay. If we're talking about like disclosures, a prohibited transaction or something like that, I think it's like a 15% IRS excise tax on that. But there is a penalty. I think it's on the data. If you don't give data, a service provider that sort of doesn't cooperate with data requests, I think there's like a $10,000 a day penalty built into it. And so that has some, yeah.
Dang.
Mm-hmm.
Do you remember Game of Thrones when, I forget her name, she had to do the shame walk?
Yeah.
Shame, that we can turn that into a segment where we have to know shame.
That would be fun. Yeah. So I want to just make sure it's $10,000 a day. I think it is, but.
And for those that don't know, Julie and I, we're really into like Viking and fantasy shows and all that.
They had really good health care on the Vikings.
We're going to attach a leech to your head and cure you. Yeah, there is just so much in here regarding broker consultant compensation, transparency, integration in the existing 408B2 rules, audit rights.
Mm-hmm. So, and here we go. For PBMs and group health plans could get this penalties of up to $10,000 a day for failing to provide required information, and up to $100,000, which is really nothing if you're talking about a PBM or something, for submitting false information. But if you, that's $100,000 per offense. So, and there's penalties in there in the CA 2026 if you fail to pass through 100% of rebates, that's going to be a prohibited transaction. So you'll be subject to IRS penalties. $10,000 a day for if any plans or PBMs that don't provide the data they have to provide on drug spending and compensation. And then there is obviously fiduciary liability stuff, but that's a lot of new penalties. That is, more than we're used to.
Yeah, we're not talking chump change.
It's not chump change. I agree.
No. And I think that's part of the problem is laws are great. Who's going to enforce them? And then what's the penalty? If you don't have penalty or enforcement, then the law is pretty much useless, right?
Yeah.
So we've had to watch a lot of litigation come into effect. And yeah, okay. This is, as you said, this is pretty impressive.
Yeah. But just keep in mind that $10,000 a day, it can be PBMs, insurers, or the plan. So that plans have to worry that if they're out of compliance because their service provider won't comply, they're subject to this penalty. So that means there's no more sort of not reporting non-compliant companies. Say you ask for a compensation disclosure and you don't get it, you're supposed to report that to the DOL in writing. You're supposed to request one in writing, and if you don't get it within 90 days, you have to report to the DOL. You have to end the contract or at least not enter into a new one. And if you don't do these things, there's now a pretty stiff penalty in place. And there's penalties for a lot of things here. So, yeah.
Changes. Mm-hmm. Wow, that's intense.
It is.
Interesting. DOL commentary. So they're asking for commentary regarding this proposed PBM rule right now. So plan sponsors have until such and such date to be able to submit. Well, not only plan
April
sponsors.
15th. Anyone can
anybody.
submit comments. Yeah.
Interesting.
And so, we're already putting comments together. This is a great thing. Everyone should submit comments. This is your one chance to sort of be heard and get in there, and they read them and they get published in the Federal Register. Sort of, we got comments about this, and sometimes they change what the rule says because of this. So if you have a good point, submit the comments. We can put in the notes if this comes out before April 15th, where you submit them. But you can also just look on the sort of DOL, the announcement of this proposed rule. They have the website right there where you can submit comments. It's to the Federal Register. And, some comments are like things that I think just sort of basic things that need to be clarified, or clarify that, first of all, TPAs are already required to make compensation disclosures under a 408B2B, because one of the things that you're hearing is, well, now PBMs have to make disclosures, but they didn't have to before. And that means I didn't have to before either. And I don't have to now because I'm not part of this. I think that the CAA 2021 was clear. And if it wasn't clear, Congress was clear afterwards, and the DOL has been clear that it applies to more than brokers and consultants. It applies to almost every service provider that's going to make more than $1,000.
And how many FAQs came out regarding 2021? I mean, I lost count at literally, I think 69.
They're in the 70s now.
They're in the 70s.
Yeah.
70 FAQs.
Although technically there wasn't a bunch about the sort of 408B2s, but there was a big sort of opinion letter in 2021, and then Congress has said a bunch of stuff, and there was another one, and they all say, like, this applies to anyone doing these things. They list out like PBMs, TPAs, things like that. But because they had the words broker and consultant before them, a lot of service providers said, no, that's just broker.
That ain't me.
So they did remove those words in CAA 2026, which I think is great. But I think also it's just great to clarify that that you're still covered under CAA 2021. If you don't have to file this new disclosure, it doesn't mean that you're scot-free in some way. You were supposed to be filing them all the time.
So this mandate pretty much becomes the new fiduciary benchmark, because it includes elimination of spread pricing, rebates, undisclosed compensation, formula-related conflicts in its essence, right?
Well, we'll see what happens. There's another thing, though. They're going to have to harmonize somehow. And I don't know who I mean by they, them, the government, are going to have to harmonize. There's some differences in the DOL proposed reg to the CAA 2026 legislation. So like in the proposed rule that we're about to comment on, you have to disclose rebates and spread pricing. And that would suggest that this is okay as long as you disclose it. But starting in, I think, 2028 or 2029, because the CAA doesn't go into effect for a while, or most of the provisions, then you can't do those things anymore. So I think that that's a sort of another comment for the rule, is sunset that at some point, because you can't do it anymore.
Yeah.
Or if you're doing it, what happened? I don't know. But those are the sort of things that'll have to be harmonized.
I guess you can't glaze over the fact that regardless of where the rule goes, being a good fiduciary means applying all these measures to how you're being prudent and loyal to your plan and your fiduciary process to evaluate what vendors you're working with in general. Otherwise, you're in a prohibited transaction.
Yeah.
Okay.
You're in a prohibited transaction. The rule already says if you didn't get a disclosure, it's a prohibited transaction. So that's if you have vendors in your plan and you don't have a proper 408B2 disclosure that discloses all direct compensation, indirect compensation, the services that are being performed in exchange for that compensation, subcontractors that are working on this, transactional compensation, compensation upon cancellation, whether or not you're acting as a fiduciary. If it doesn't have every single one of those things on it, you don't have a proper disclosure.
What if I'm a plan sponsor who becomes empowered? They're educated now. They're empowered to take action, and they discover that I have an advisor or I'm using a vendor, and I uncover that they've been making not a little bit of extra money, but like hundreds of thousands of dollars. Is there some sort of recourse that I can take outside of just firing their ass?
And sue them.
Oh, plaintiff's attorney.
Yeah, I mean, and that happens. We've seen cases where especially where a plan sponsor thought that there was a sort of limit on the compensation that was only direct compensation. And when they found out that there was also indirect compensation, they freaked out and sued. And so we saw Osceola County when they sued Gallagher years ago.
Oh my God.
Yeah.
Yes. Oh.
And
That's so many cases ago, but it was a paramount case
Mm-hmm.
in the industry.
That's right. And that isn't even governed by ERISA. And that's what, so if you're like, oh, well, I'm a non-federal governmental health plan, it doesn't mean that everyone should know what they're paying service providers to a plan, especially because you're paying them with other people's money in part. And in a public plan, it's a combination of employee money and taxpayer money. And in many cases, there's heightened duty to be, good stewards. And state law varies and the trust documents may vary, but no matter what, you should be getting compensation disclosure.
You should be.
Mm-hmm.
You should be. I guess let's define plans that are covered under ERISA, right? So we deal with commercial plans, large, small, fully insured, self-funded, level-funded, captives, blah, 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 blah. Non-federal government health plans, and then Taft-Hartley funds. So who in that is covered under ERISA, who isn't?
Okay. If you work for a private company, and even if you're a union member and there's, you're in a union bargain plan, if you work for a private company, it's governed by ERISA. Mm-hmm. Unless that private company is a church plan, there is an exemption for church plans, and they have to fit a specific set of criteria established by a church, maintained by a church. And weirdly enough, though, there are church plans that people who work at hospitals sometimes are part of, because they can claim that a lot, and then they're not subject to ERISA. That happened more in the 401k space, though. In fact, most health plans do elect to sort of have ERISA protection when they can. And then if you are a state, municipality, school board, any sort of, if you work for the government, and it's not the federal government, then you're in a non-federal governmental health plan, not subject to ERISA, but subject to CAA, subject to ACA, subject to HIPAA, almost the same requirements. And many cases many plans adopt ERISA standards in their plan documents, in their trust documents. There are state laws in place that sort of mirror ERISA protections. So ERISA is a pretty good benchmark for what should you be doing. That being said, the Department of Labor is only going to go after, private.
Understood. But there's still a fiduciary standard for those
Oh,
stuff,
yeah.
Right? I mean, it's taxpayer dollars, yada, yada. Mm-hmm. And then Taft-Hartley falls under ERISA as well.
Usually,
or
almost
labor
always,
rules.
yeah.
Mm-hmm. Okay. All right. Good to know. But ERISA doesn't necessarily apply to small group, fully insured plans.
It does too.
Okay.
Yeah,
Tell
I
me
know.
more.
And people think it doesn't. If fully insured plans are also governed by state law because the insurance company is regulated by state law, as only self-funded plans are exempted from state law, but all private plans are subject to ERISA. All.
Okay.
Mm-hmm.
Okay. And CAA applies to all regardless.
Almost every provision applies across the board to everyone. And so, for example, when you see mental health parity violations, you see it just as often against carriers and fully insured plans than you do against, self-funded plan. And ERISA, the DOL goes after carriers a lot of times to try and, sort of deal with something across the board that happens in fully insured and self-funded plans. So, yeah. If you're in a fully insured plan, ERISA does apply, and you still have a duty to, selecting your service provider is a fiduciary duty. So you have to be, that is always something you have to be concerned about.
It's an interesting time in our market. Regarding the FTC mandate, what do you think the impact will be? And do you think that this is a signal of the end of these behemoths, or do you think that they'll adapt or too big to fail?
No, I do think that it's already much easier to not use that model in the PBM world than it is to do anything different in the medical side. And, there are already transparent PBMs, large ones that you can use. And we have Mike Neely on last month, and he works for a very big transparent PBM. There's lots of places that are like this now. So this is a choice if you stay with, one of these big three. And it is so to me, it seems like there's going to be a quasi attempt to adapt because
Yeah.
things are changing.
Yeah.
And, I think when I was reading, again, I think Cigna, they anticipate that like 50% of their business will be in that model and within several years. So I do think they'll still have that, but they still want to be able to offer those other plans. And I think it remains to be seen if that's viable, given the CAA sort of tries to eliminate a lot of those practices. The FTC order clearly suggests that that's not what a model of a good plan looks like, because that you're required to have a standard offering without it. And now we're getting this prohibited transaction litigation. One of the things you're going to have to prove is that the contract itself is reasonable. Well, if there are other contracts that don't do this and the plans save a lot more money when they use them, how long is it going to be reasonable to use a contract that you lose a lot of money on?
Yeah, that's a good point. I see this as regardless of where you're at in the buying process or education. I'll go back to what Jamie said when we had her on. You just need to start, right? And let's face it, there is no bulletproof, perfect health plan that exists that is going to work for every single person in your population. But it's this constant evaluation and progress towards perfection, even though it might never be reached, that people need to strive for. And they need to seek out sound advice. And I understand a lot of this is a relationship business too. But at the end of the day, that relationship isn't going to save you from fiduciary breach, prohibited transaction, lawsuit, etc. And at the end of the day, it's oftentimes your own money too, because you're part of that health plan if you're working at that plan sponsor, right?
And even if you're not part of it, you pay the lion's share of it as the plan sponsor. And so you could really, here's the thing, being a better fiduciary, it has a huge ROI. We were talking about this earlier. Millions and millions of dollars a year once you start getting things into place and carving things out and putting in direct contracting. Do all these things happen overnight? No. But where's a good place to start for people that don't know where to start? If you own a business, the core of your business is entering into good contracts. You negotiate over everything, over paper clips, over how much you're going to pay for anything. That's what you need to be doing in your health plans too. And the bonus is that you're required to enter into contracts that are reasonable. And if you're going to be subject to, prohibited transaction litigation risk, one of the great defenses to that will be to show that you engaged in a sound fiduciary process to negotiate good contracts. And so that is not as hard as it seems. And, is it going to be perfect? No. Could it be immeasurably better than what you have right this minute? Oh my gosh, yes. I mean, some things that are in these contracts are unconscionable. And if you ask to get rid of them, they're out.
It's really, really crazy. The standard is rising. You have to elevate those standards. And ultimately, I think the alternative is it's unsustainable. And I've seen people making some very dire decisions in how they structure their plan. And unfortunately, the easy button for most people is just a cost shift to employees. And when we talk about the different demographics we deal with, like Alice, asset limited, income constrained yet employed, they've been pinched enough.
And they just don't have any more money. I mean, there's no much more you can shift to them. The average cost in a regular plan right now for a family of 4 every year is it's like $26,000 or something.
Yeah.
That's a lot of money.
Yeah, if not higher, depending on the region in the country, which is insane. Oy. Well, there's a lot of opportunity here, and it's good to see some support from the federal government.
It is, and it's good to see things happen. Okay, so here we go. 2025-2026, the average cost of employer-sponsored health insurance for a family of 4 is $27,000 a year. It's a new car every year. And for many, costs exceed $30,000 annually. Now, a lot of people make $30,000 annually. I mean, I don't know in what world can anyone afford that. It's just not sustainable. And the employees pay the least amount of the cost. The employers can't sustain it either.
No.
And so something has to change. And I think that that's sort of the impetus behind this is everyone is squeezed as thin as they can get. And so something has to give.
Except for politicians in Congress, right? Don't they get health care for life?
Yeah, but and that and we pay for it. And do you think, I'm sorry, but do you think the federal employee benefits plan is perfectly run? And do you think they have good contracts? I've seen their contract, and there's alarming provisions in there too.
I believe it.
Yeah.
I believe it.
And so one of the things that's helpful is sort of identification of like right now, everyone should know that their contracts with TPAs and PBMs, if you're self-funded with your TPA, are full of like these anti-competitive provisions that are illegal here and elsewhere. But like of course, if you're a self-funded plan, the reason you did this, presumably, is so you could carve things out of that plan and design it the way you want. Of course you can. So don't agree not to do that. And in many states, it's illegal, even if it hasn't been made illegal in health plans specifically in the federal government yet. Although I do believe that's illegal. But you can argue that.
From an anti-competition perspective,
it's an
or
antitrust violation. Yeah.
Okay.
And so I have negotiated that on behalf of all size plans, and rarely have had a carrier come back and be like, no, you cannot do any direct contracting unless it's a really small plan. Really small plans have a really difficult time in the self-funded environment, and it's probably not the best space if you're too small.
So, just thinking out loud here, anything that would block you from being able to work in the best interest of your plan, you really need to question. You really need to strongly question why you're in that relationship. And I think certain parts of the country, there may be limited providers that you can lean on, which is highly unfair for these folks. They have no other option. In other parts of the country, you probably do have options, and you have to, as much as it is a challenge, read that ASO agreement, read those contracts, which are sometimes 100 plus pages, or hire good legal counsel to be able to review those agreements.
So we have a joint friend. Shout out to Stephen Caraba now. And he always says, and obviously I like this as an ERISA lawyer, he's like, you spend millions of dollars. Is this a good impression? You spend millions of dollars a year on healthcare. You really should spend, I don't know, $2,500, $5,000 and have someone look at your contracts. And, it's pretty sensible to make sure that somebody is looking at your contracts. Maybe it doesn't have to be a lawyer. Not everyone needs an ERISA lawyer, but you need someone reviewing your contracts that knows what's good and what's bad and can at least advise you on it, because you have to be able to defend this and say, this is a reasonable contract. And if you don't even try to get out the bad stuff, it's going to be pretty hard to show that you were a good fiduciary. You don't have to win all the time. You do have to try.
Oh, and we've seen people get charged for things that are not in the contract, and we've saved plans hundreds of thousands and millions of dollars because they were getting dinged for something that they never agreed to. And for you emo fans from the early 2000s, Stephen Caraba's first cousin is the lead singer of Dashboard Confessional. So if you were a fan like I was, you can at least connect with him either for his wonderful claims analysis and or because his cousin still tours.
Well, that's a fun fact.
It is a fun fact.
What other fun facts?
I said it jokingly once. I go, I can't remember the guy's name, but it's also Caraba. I go, are you related to him? He goes, yes, my cousin. I just saw him at Easter or Thanksgiving or something. I'm like, no way. That's so funny.
And then we've got, all right, who are our other famous people that we know? We've got Jed from Home Alone.
Yes, Jed Cohen. So Fiduciary in a Box, one of the co-founders. Jed was he was one of the kids in Home Alone. He goes, I was the Jewish-looking kid, part of the Italian family.
And I believe he got thrown up on, right?
It's very possible.
Yeah. Like Kevin, or he was the thrower-upper. I can't remember, but
I don't remember. I look for him every year in the movie. Yeah,
he's in part 2 as well.
Yes. I think, is that the limited extent of our famous friends?
I think it might be. Yeah.
Oh wow.
We gotta class this joint up a bit. No, I'm just kidding. So things are changing, and again, what are you supposed to do if you're an employer or you advise employers? The market is changing, and that's good. That's great. That's what everybody wants. And so all you have to do is just a little bit right now and start by like, I think I'm going to try and negotiate a better contract this year with my PBM. Start there, because you have all this leverage. I want a contract like what the FTC says is the standard offering. I mean, basically one of the big three has to offer that. And so now everyone's going to have to offer it. And by the way, there's lots of PBMs already out there that have had that for years. So in the PBM side, it's harder, I think, a little bit to justify not doing these things already.
Yeah, and you have to, once again, you can be sold a bag of goods. You have to read the contract to make sure it specifically states the things that you're, being told you're being sold. As we get a lot of people in our industry are like, oh yeah, I do that. Yeah, we do that.
Yeah.
We're transparent. We're transparently, bending you over.
Words are great, but written contract language is better. And also, like, when do you have leverage? Not after the contract signed and then you want something that isn't in your contract. All the leverage is in negotiating the contract. And you have the most leverage if you're doing an RFP and, people want your business. They're auditioning for you. Your current vendor's trying to get you they're being a pick me, And so that's when you can get things. That's when you're most likely to get things. And right now, if you're negotiating a PBM contract, there's like all this stuff out here that you have to rely on. You're like, I want a standard offering and I don't respond to this RFP unless you're going to give me one. And I want something with zero rebates, zero spread pricing. There's all kinds of things you can ask for right now.
Tons. And you're taking the first step by listening to the EOB.
Yeah. So I think it's a really good time for this stuff, and there's a lot going on. I'm sure we'll talk more about all of these things, as time goes on, but basically there's clearly, even though they're all a little bit different, there's a whole bunch of stuff happening around PBMs right now. So if you're going to focus on, like, say you wanted to make a March resolution and you're like, I'm going to be a better, plan fiduciary starting today, start with your PBM. I mean, there's a lot of room for movement there.
It's like a love song. Start with the PBM. Sorry. Horrible. Cheesy guy over here. We want to continue to produce good quality content, and in that we need to hear from the audience. So we've reached that point where we have lots of folks that are listening and watching, and we couldn't be more thankful. But we want you to contact us. Hell, we want you to come on.
Yep.
Be part of our Friends with Benefits segment.
And also, tell us what you want us to talk about or what you want to hear about or who you want to see. And then we have a reason to say you have to come on the podcast because we got all these requests for you. So, we're totally open to audience requests for content. But until then, we're just going to keep talking about, whatever's happening that seems new. And I think like the next thing we might talk about is direct contracting.
Oh, direct contracting. I love direct contracting. Actually, I have somebody who's an expert in direct contracting that we can have come on. And I know that we have clients that we're working with to develop their direct contracts with plan sponsors and go-to-market strategies, which is fun.
Yeah. And also, this is another sort of fastly, is that a word?
Expeditiously?
Quickly developing trend, all right? One, direct primary care. Everyone loves that. Everyone, this has sort of been a push to get this for a long time, to be able to have this and also have a high deductible health plan at HSA. The rule is still messed up. And so there still really isn't first dollar coverage for it. Sorry. However, I know that comments have been submitted to the IRS asking them to fix the language, at least of their bulletin. So we'll see what happens there. However, what is happening is that we're seeing direct contracting take off everywhere. And so it's like, Surgery Center of Oklahoma has been around for a long time, but now all of a sudden there's surgery centers, all around popping up and freestanding facilities and physicians groups and, hospitals are starting to direct contract all over the country. Indiana has passed it. I know I keep talking about Indiana like a weirdo and I've never been there yet.
You love Indiana.
I do, because they have a law now. And if you're a public hospital in Indiana, then by 2029, you have to offer direct contracts to employers. And so that to me is a real game changer. If hospitals can work out contracts that employers can sign on to that sort of work for both parties, it seems to me that's the time when, regardless of what you think of hospitals and what hospitals think of you, that, it's one of those, not that anyone's an enemy, but the enemy of my enemy is my friend. Why, we're both complaining about the same thing all the time, and it happens to be the network in the middle. go around them. You don't need it.
Wait till you hear the podcast with Dave Belinsky on our Friends with Benefits, where we discuss hospitals as a public utility, as a potential option. But direct contracting is here to stay, and it is going gangbusters on all levels right now. So we're looking forward to delving into that a heck of a lot more here in an upcoming episode.
And what I think is even more crazy is direct to employer drugs. I didn't have that on my bingo card. And I was wondering what was going to happen earlier this year when Trump announced Trump RX. And, you have all these sort of, if you're uninsured, you could buy directly already from like Eli Lilly and places like that. I'm like, oh, everyone's in, only employers are left out. And Eli Lilly, they're the first ones to sort of jump on this, but they won't be the last. So, basically last year, they lost their place in the Caremark formulary because, there's apparently a better agreement between Caremark and the maker of Wegovy. And so the answer now is that they're coming direct to employers and offering it at a lower price than employers were paying under their plan. Things like that are going to take off.
They're offering it at a great price. I mean, $450 a month for Zepbound.
Yeah. I mean, that's cheaper than most employers are paying, even with rebates, over $6 a month. So, and if they were getting the full amount of rebates. So it's a good deal. And if that starts to happen with more drugs, then, there's still some sort of, what's weird is there still has to be some entity in between the manufacturer and the employer to make this work, but it just won't be the PBM. I don't know how it's going to work.
I don't know, but it's kind of exciting too. And if you think about it, Dave Chase and Sean Shanson have been promoting this forever. Out of every dollar we spend on healthcare, only like 20 cents goes to actual providers. Targets on middlemen being eliminated. And Eli Lilly has taken a big step. And let's face it, GLP-1s and every variation after that, they ain't going anywhere.
No, I know. Oh my God. You look around and everyone's so skinny. It's just skinny.
We should have a peptide expert on. I got a buddy that's really into peptides and is building a business, so we can talk about that.
All right. I think I put peptides on my face, but I don't know what else we're doing with peptides.
Oh, there's
like vitamin C stuff.
RFK wants to release the peptides, like 17 or 18 different peptides, but they're very powerful.
Are they like, how do we have to drink them in raw milk or is there?
No, I think you subcutaneously inject them.
Oh, really?
Yeah.
Why is everything by needle nowadays?
I don't know, but GLP-1s now have a oral.
I heard there's a pill.
Yes.
Yes. But is it as effective? Do we know?
I have no idea. We'll have somebody on to discuss that.
Yeah, so we're going to discuss everything.
Yeah, we got a lot of business, but we appreciate you making the time to listen to the EOB. This is an honor to be able to educate the community, and we're looking for your feedback, so please provide it.
Thanks for listening, and we'll see you next time.
See you next time.
Bye.
Welcome to EOB, where the fine print gets airtime. We take the plan docs and hot takes one clause at a time. If benefits feel murky, confusing, or buried in law, we'll translate the jargon and